All right, September 27th, Tuesday. We're going to begin Unit 2 today. Now, as far as Unit 1 assignment goes, again, it's keep working on it. If you're still working on it, everything's due by December. You could do this course at your own pace. But again, as long as you're working on Unit 1 assignment, getting some of it knocked out, that's excellent. Just don't put it off too much longer. And if you have questions, certainly reach out and I can help you. So you should be seeing the Word document for Unit 2. Again, I tried to put this into a Google Doc like I did with Unit 1 assignment, but there's so many identification things and images, and it just none of the 2 through 5 didn't blend at all into Google Docs very well. So I just left them as Word docs. So you'll be just click Unit 2, click the Word doc, it'll download it to your computer, and it's yours. You can type right into it. So we're starting on skeletal system, joints, and muscles. So we're going to do that this week and next week. We'll meet in Zoom next week as well. And then the following Tuesday, so 2 weeks from now, we'll be meeting back on campus, and we'll go through a little bit of nervous system that day. And then we'll be dissecting sheep brains, and we'll talk about special senses a little bit. And we'll dissect cow eyeballs as well that day. So, but anyway, I'll send out announcements and reminders as we go. So let's get going on skeletal. You can see the first several terms in your Unit 2 assignment are going to be some of the basic terminology that we'll find both in visible body as well as OpenStax, as well as the lecture notes. So again, what you do with these, how you fill them out, totally up to you. Let me see if it'll do it in here. I know in Google Docs you can, but if I click that, right click. Yeah, try to see, there we go, translate maybe. And then there's synonyms. Oh, that's just for the thesaurus. So if I hit translate, it'll be sent to the internet. If I click yes, let's see what happens. There we go. Hematopoiesis.
Hey Kevin,
Yo.
are we allowed to put it what it says directly from the internet into the
Sophia,
table?
you do it however you want to do it. Yep.
Okay, thank you.
Yep. So here we go. So when you're in a Word document, it's a little different than a Google Doc. Not much though, but if you're in a Word doc, you can highlight the item, the term, right click it, click translate, and you'll get this little box, a research box over here, and it'll land on translation, which doesn't give you much of anything. We want the dictionary definition, so you can click dictionary and it'll pull up some information. Formation, so hemato, and it'll also give you, what's nice about this, especially for a word like hematopoiesis, right? That's a tongue twister. So this will help you with the pronunciation as well. Hematopoiesis. All right. Anyway, these are also in visible body. They're also in OpenStax. So anyhow, the formation of red blood cells in the blood forming tissues of the body. All right, copy. Formation of red blood cells in the blood forming tissues of the body. So what are the blood forming tissues of the body? We're going to learn today bone marrow. Okay, so bone marrow is where the formation is, where hematopoiesis takes place. So, but anyway, there you be on those. Okay, so the first several, let's see, it looks like about the first 30-ish or so terms: endochondral ossification, interstitial growth, apositional growth. And we get to about 33. These are kind of just basics of bone micro appearance. So you're going to see some cellular discussions of bone. You're going to osteoblast, osteocytes, osteoclast, osteoid, osteon. That's all. Remember when we were going through cells and tissues, when we get to a new system, first thing we do is go through cells and tissues. So that's what's going on right away with this. We also see, and again, I'm going to go through visible body. It's going to go through some of this in more detail. But anyway, you're going to see how we can classify bones. So that's what some of this terminology is there. So anyway, the first 33 or so relate directly to the skeletal system, how it should appear. And then the next couple, maybe 5 or so, are going to be some pathologies or diseases of the skeletal system. Some common, well, I mean, not super common, but relatively common. So the osteomalacia down to osteomyelitis, this little group here are going to be some pathologies for you to look up. And then we transition into joints. So that's what the next little section is. What's a joint? Simply put, it's a bone and a different bone coming together in some way. Okay, so a bone and a bone make a joint. Okay, so we'll look at that further in visible body today. But anyhow, you'll have some joint stuff there. And then you'll have some basic joint actions. Okay, so joint action terminology. Okay. And then we get to muscles. So we're not going to make it here today. So I'm not going to, this is my goal, is to get through the majority of skeletal basics and joint basics. Will we get through all of that? I don't know. We'll be close. Probably going to get to joints though. Next week, we'll probably be picking up where we left off, and then we're going to get into muscles. So first off, we can see, oh, and by the way, with bones, you know, osteo or just OS or OSTE, those are going to be kind of your roots or combining buzz terms for bone. So when we see osteo or os, we're probably dealing with something with bone. When we see chondro, CHONDR, that was going to relate to cartilage. So we'll see later today that cartilage, we saw cartilage a little bit last week with our connective tissue. We saw bone a little bit last week. But anyway, keep that in mind. And then when we get to muscle, we see MY, MY, MY. And then down here we see MYO. So my/O, that's the combining form for muscle. All right, so muscle. So epi means upon, peri means around, endo means inside. So we're dealing with different layers of a muscle. So we'll get into that a little bit next week. We also see the word tendon. A tendon connects a muscle and a bone, whereas a ligament can, in essence, provide stability at a joint. So we see a ligament attached at a joint between one bone and another bone, okay? A ligament. So if you sprain your ankle, you've overstretched a ligament. That's a tear. So like a 3rd degree sprain is likely going to be like a tear, a torn ligament. So anyway, just a handful of items on muscle. So a lot less in the way of terminology compared to Unit 1, right? We're under 100, so that's good. Then there are a couple of terms regarding muscle actions and what they do, because when we talk about muscle, we're specifically talking about skeletal muscle, right? Last week, we introduced you to smooth skeletal and cardiac muscles, muscle types. So cardiac, we'll cover that when we get to the cardiovascular, and then smooth we'll cover when we get to cardiovascular as well. All of your blood vessels are smooth muscle. And then really the rest of the semester, digestive, respiratory, urinary, reproductive, those all generally are going to be smooth muscle tubes. So skeletal muscle involves moving the skeleton or the bones across joints. So tendons are going to cross over joints and create movement. So we'll get into that next week. These are just some kind of different types of actions and movements that muscles can create. Okay, so visible body, this is where we're heading next. So, as we're doing, I'm going to be pulling up visible body and going through that. But again, a lot of your, not all, but a lot of the images within your Unit 2 assignment come from visible body directly. So here's the list I put together of the different bones of the skull. That's going to be the most, the most bones really condensed in the skull and facial area. So we've got the frontal bone, your forehead, and the parietal is your crown. And then the occipital bones, we have two parietals, one on each side, a left and a right. And then we'll see the occipital bone at the base or the back of the head. Then we have two temporal or temple bones, and then a sphenoid that kind of nestles itself within there until it forms kind of the floor of the anterior portion of your skull, along with the ethmoid bone. The ethmoid is the roof of your nasal cavity. So we'll see some holes where your basically the sphenoid and ethmoid. This is where we're going to see, a lot of your scent molecules traveling up to what we call the olfactory bulb. So we're going to see sense of smell with the ethmoid. And then we get into the mandible. Vomer means plow. That's one of the bones that makes up the septum of the nasal cavity. And then the maxilla, which is kind of your upper jaw. And then your cheekbones are zygomatic. There are a couple terms for cheek. Zygomatic generally means cheek. And then we also see buccal. We'll see a muscle called the buccinator next week, but buccal, B-U-C-C, that also has to do with the cheeks. And of course, the nasal bones, lacrimal, and then the palatine, which is your hard palate bone at the roof of your mouth. And then we'll see a couple sutures as well. By the way, this is your first set of joints. Sutures are immovable joints. Remember, a joint is a bone and another bone coming together. Well, in the skull, we have the frontal bones meeting with the parietal bones. So you're going to have a suture line across here. Okay, so technically it's a joint. And then we have another suture line going right down the middle that's going to join the parietal bones. And what's that plane, right? That's the sagittal plane. So we could call that the sagittal suture. So anyway, sutures, those are immovable joints. And we're still on the axial skeleton. Axial means down the axis, right? Down the center. So the skull, vertebral column, and ribs make up your axial skeleton. So we'll look at the vertebral column coming up, and then the thoracic cage or the rib cage. Okay, so that will take us then to the appendicular or the appendages. So we'll see the shoulder girdle, which is your collarbone and shoulder blades. All right, that's what you know them as. That's what your patients are going to call them. Clinically, though, we call this the clavicle. So clavicle and collarbone are synonymous. But again, you're not going to write collarbone in your charts or your history forms, even though the patient's going to call it that. And then the shoulder blade is also known as the scapula clinically. So those actually come together out here at that acromial area. We call this the AC joint, acromioclavicular joint. And then we'll see the clavicle also meets up with the sternum right down the midline there. So anyway, but remember the sternum is going to be part of the axial skeleton. The sternum is part of the thoracic cage, but the collarbone and scapula, or the clavicle and scapula, those are technically appendages or part of your appendicular skeleton. Okay, and then they form, of course, the or connect with the arm. You have the humerus. We have the humerus. Now that's the upper arm bone. The medical term for arm that we see oftentimes is brachium or brachial. So B-R-A-C-H, Brock. Kind of like, I think there's some candies, Brocks. They make the mints and those kind of hard candies. They probably have chocolate too, but Brocks, brachial, that means arm, specifically the upper arm. So you might see that when we get to nerves and blood vessels, they're going to be named for that. All right. So anyway, humerus, and then we have two forearm bones, the radius on the thumb side. So the radius is on the thumb side, and then we'll see the ulna is on the pinky side. So in correct anatomical position, like our guy is back here, the closer to the midline, so palms facing forward or anteriorly. So the pinkies would be closer to your body. So we'd say the ulna is closer to the midline. The ulna is medial and the radius is lateral. But we also say ulna is on the pinky side, radius is on the thumb side. And then we have the carpal bones or the wrists, and we'll look at some of the hand as well, the metacarpals. Let's see. And then we head down to we have the pectoral girdle or shoulder girdle, collarbone and shoulder blades, right? Clavicle and scapula. The lower girdle is called the pelvic girdle. Okay, we also know it as the hips. So they call that the coxal bone, and we're going to see three major aspects of that, along with a couple other key features. All right, that takes us to the leg, the lower appendage. The largest and longest bone of the body is the thigh bone or the femur. Then we have the patella or the kneecap, and then your shin bone or your tibia. Type that in. Shin bone, and then this is your weight-bearing bone. This is going to be more medial as well. So when you palpate your shin and you travel distally down the shin toward your ankles, you'll feel your shin continues to become what you maybe know as your ankle bone, that bump on the inside of your ankle, right? And that's actually your tibia. And then laterally or toward the outside, you feel a little bone there. You travel down, it kind of disappears maybe a little bit, but then under some of the muscle, it'll reappear as that other ankle bone, right? That bump on the outside of your ankle. That's going to be the fibula. Lateral malleolus is that bump. And then the medial malleolus is the bump on the tibia. That again, a lot of our patients are going to call their ankle bone. Okay? That's why you guys, we should be teaching anatomy to children, right? Kids, K through 12, you should have a little bit of A&P. So then, when you grow up and, you have, you don't have to rely on doctors to tell you everything. So you already have an idea. And then you just need them as needed. Anyway, I'm partial to anatomy education, as you can probably tell. So anyway, ankle bones are actually called tarsals. So your heel bone is known as the calcaneus. That's actually one of your ankle bones. We have 7 in each ankle. And then your feet, those are called metatarsals. And then phalanges, those are fingers and toes. So anyway, that's the long and short of it. We're going to try and look at all those today in our visible body. All right, so then you've got some visible body. We'll see this today when we get into visible body, so be able to identify what all of these are. And then bone classification. This is a long bone, short bone, flat bone, irregular bone. And then just identifying the different bones of the skull. Again, these are from visible body. These are from my lab. These are from our lab. So which vertebra are we looking at? So without the E on the end is singular. So one vertebra. When we have multiples, we put an E on the end and it's called vertebrae. So the plural for vertebra is vertebrae. Okay. Distinguishing features between these, certainly we've got 3 holes. Tells me this is a cervical vertebra. Okay. This one looks like a giraffe profile, sort of, got the long spinous process. That tells me that's a thoracic, and it'll only have 1 hole. If we were to look at a superior view of this, we would only see this hole in both, like kind of like this. See how this lumbar has a giant body, and it looks like a moose in a profile, but there's only 1 hole or foramen in a lumbar, just like with the thoracic vertebrae. There's only 1 hole there as well. But the distinguishing feature between, so anyway, cervicals have 3 holes. 1, 2, 3. Thoracic and lumbar have 1 hole. Now, how do I tell the difference between a thoracic and a lumbar? The size of the body. Lumbars, your low back, they have a lot larger diameter body. Usually it's also a little thicker. We also see more of an elongated spinous process with the thoracic vertebrae. We see these kind of big facets where the ribs kind of swoop in. But anyway, thoracics are a little smaller than lumbar. What's this big hole for? It's for your spinal cord. Yeah, it's for your nerve, the big nerve, the long spinal cord that comes off of your brain. And then this is your tailbone, called the coccyx. And then this is your sacrum. These are all part of the vertebral column. And then so we're in the axial skeleton identification here. We've got a clavicle, looks like a patella, a scapula. Yeah, so it's got a few bony landmarks. So these different letters that we see here are bony landmarks. Also, I ask you maybe like which is this the left or the right? Is this the left or right bone? Well, this part right, first of all, this is called the medial border. This straight up and down medial border. This is called the lateral border. Okay. This is the superficial and superior aspect that you can palpate. This is called the spine of the scapula. And then this little groove here is the socket for your shoulder. So your humerus would fit right in here. So we're looking at a left scapula. Okay. This is toward the spine. This is where the left arm comes out. We're looking at a posterior viewpoint. Anyway, so we'll get into bone identification, and then next week, and then a little bit with joints, and then next week we'll get into muscles. All right, so we're going to do a new share. We're going to zoom back over to the interwebby. All right, you guys are you guys on the internet now? Or you can see on my screen. All right. So let's go to visible body. Okay. So skeletal system. And by the way, a few students, I don't know if any of you in here today or any of you watching the video, a couple of you have asked specifically in visible body if you need to do the practice quizzes or any of the assignments, that like the lab activity, lab activity? The answer is no, you're not required to do that. The only requirement in visible body that I grade and enter into the grade book, and again, if you've done some of your visible body quizzes, you don't have a grade yet in Blackboard, that's okay. I usually go into visible body every couple of weeks. So this Sunday, I'll be going, because then we're done. Most of you, if not all of you, have likely done some quizzes in visible body. So you have some points. So I'll be transferring the points in visible body over to Blackboard. So for whatever reason, they're not congruent with one another or connected. I can't link the two grade books. So I have to manually enter them. So anyway, that question has been brought up. The other question is, do I have to do anything else in visible body other than the graded quizzes? And the answer is no, you do not. You only need to do the graded quizzes. Okay. I'm not telling you not to do the other stuff if you'd like. I mean, it's totally up to you. But notice we do have a few different items here. We've got this one that says pathologies of the skeletal system. So if I click that, it's going to open up a few different pathologies. Spondylosis, that basically means, osis means condition of, and a spondyle, that's kind of like a spiky, bony protrusion, almost like a bone spur. So, we're seeing a lot more patients coming in that either have some sort of spinal stenosis or some sort of spondylosis or spondylitis. Even you might be inflammation of that area. And what happens is, the spinal cord goes down through all of your vertebrae, but coming out laterally from the spinal cord are spinal nerves. And so as we get older, or if we have a disorder, the bone density or thickness of the bones can start to thin out a little bit. And in the meantime, we might be adding bone or spurs to different parts of a vertebra. So the body of the vertebra might be getting bone leached out of it. So we can add bone to an area where there's excess stress. So in the neck, because a lot of us are like this so much, we're seeing different musculature being used excessively. And remember, all those little bumps and landmarks coming off of bone, they're either where a joint is formed or where muscles and tendons and ligaments are attached. So when muscles / tendons as well as ligaments are connected to these bony protrusions or bony landmarks, if there's stress put on that bony landmark, your body will respond to that stress by adding more bone to that area to support that excess tension. So when you're putting excess tension on a bone, your body will start adding more bone to that area. And where does it get that extra calcium and phosphorus from, the minerals it needs? It's going to get it from itself, a different area of its own bone potentially, or it could leach it from neighboring bones. So then as you're adding more bone to one area to support the excess stress, you're depleting bone from a different spot. Thus, the integrity and the density of that bone is going to be diminished. So then you're dealing with potential osteoporosis, the condition of porous bone, along with spondylosis or spondylitis, where you're getting bone spurs. And what happens between each of these vertebrae or each of these vertebra, between each of them is where all of these spinal nerves come out. And these spinal nerves, then if I add some, if I have bone spurs near where the spinal nerves are coming out, then I get pressure put on the nerves. And so then our patients will have pain and sensations that oftentimes are why they come to the clinic. A bulging disc, right, or a herniated disc, that can also put pressure on a spinal nerve, leading to some definite pain that is intolerable for most. So anyway, again, I put a couple of I think I put 5 or so diseases, pathologies in your list. You know, you can go further. The pathology view of each of these is pretty fascinating. So, you know, if you've heard of a herniated disc and wonder what it looks like, you can just click that. It'll pop us up an image. Some of these other windows. Oops, I hope I didn't just, okay, yeah, you know, when we're in Zoom and I'm recording, visible body can take a little longer because it's pretty beefy. Just close all these windows. Hopefully I don't close our Zoom session. Here we go. So anyway, if you click on any of those pathologies, you're going to get an image at some point. Well, we're not worried. Oh, here we go. Muscle premium. All right. Well, that took too long for my liking. So we're gonna, I mean, if we weren't in Zoom and we click that, it would pop right open. So anyway, let's go back. So you don't have to do those. There's nothing to do other than view them. So if you want to view some skeletal muscle pathologies or musculoskeletal pathologies, there you go. Anatomy ID, kind of the same thing. It'll give you a full skeleton, a 3D view. So when you're going through and doing your bone identification in your list, you can pop that open and it'll give you the entire skeleton, and you can manipulate the skeleton. You can twist them, turn them, spin them, zoom in on them. You can also, tap. You can also push on a specific bone and it'll highlight it for you. And then you can get a better look at what's going on there. All right, well, while that loads, we'll go back to there we go. We're going to go to the first one, modules, practice quizzes. Okay, here's that one. It finally popped up. So let me go back over here to show you what I'm talking about. You guys remember that? A few seconds ago, I just clicked the skeleton. So again, you can zoom in, you can click on specific bones, highlight them, and work it that way. So we're going to just get off of that because again, like I say, this is a pretty, there we go. Boom. All right, we made it. Whew. Guys hanging in there? I'm still getting over my thing, it's been like 2 or 3 weeks now, and I feel awesome, by the way, but you can tell I still have a little bit of something going on. Yeah, whatever. I drink a ton of water, vitamins, minerals, I eat right. So I'm beginning to wonder if it's not something else. So let's see, like environmental, like the place I'm living might have like a mold problem or something. Because when I leave and I'm gone, I'm fine, and then come back in and it's like, so I don't know if it's allergies or what. So anyway, it shouldn't take this long to get better, is my point, no matter how old you are. So let's see, skeletal system. We'll keep her moving. 206 bones in an adult skeleton. So you can certainly watch the video. It just gives you a little overview of what's going on. We talked already about the axial versus appendicular. Again, axial means the axis, kind of the midline, I guess you could say. So down the middle of the body is going to be the skull, vertebral column, and then that thoracic cage. And then you get to the appendicular skeleton. And again, you can see highlighted the clavicle and scapula, and then the arms and then you have the pelvic girdle, and then the legs. Okay, so that's your appendicular skeleton. Why do you have a skeleton? Well, I think it's pretty evident for certain things. We talked about movement, right? And support. So our joints provide, and along with muscles, provide the movement, and the support is there for all of our soft tissue. So your skin and your muscles need some sort of support. Without a skeletal system, we would just be we'd be a blob of jello, basically. Protection of organs, yes, absolutely, especially the some of the key organs. The brain is pretty important, and spinal cord, right? And then of course the lungs and the heart. So notice we don't have much in the way when we're looking at the abdominal area. There's not much bony protection there. So it's not that those organs aren't important. They're just they have a different type of protection over top of them. There's a lot of fat and muscle that helps. Plus, if all this was bone, like if we extended the rib cage all the way down and covered this up, that would make this kind of action and some of our ability to twist and turn and flex our trunk would be almost impossible, right? And then the other thing, that hematopoiesis that we talked about, or erythropoiesis, the production of red blood cells, production of all blood cells, but especially red blood cells. So when we look at the inside of a bone in a little bit, we're going to see bone marrow, and we'll see that bone marrow generally is going to be yellow when we're adults, but there are a few areas where bone marrow has to remain red. Red implies red marrow means that there's red blood cell production. So the sternum and the hips continually produce red blood cells throughout our lives, whereas our arms, our appendages, especially arms and legs, they don't produce any more red blood cells. So the marrow becomes yellow. So anyhow, let's look at bone types. We have what are called long appendages. So your arm bones and leg bones are going to be considered long bones. Short, so they're longer than they are wide. Whereas a short bone would be taller and not long. It's going to be more boxy. So generally, we think of the carpals, which are your wrist bones. You have 8 in each wrist, and then your tarsal bones are your ankle bones. Those are generally considered to be short bones. And then you have what are called flat bones. Several of the skull bones, I think the flat part just means they're relatively kind of thin and flattened out a little bit. So we see the skull bones, the sternum is a flat bone, the ribs are flat bones. The pelvic girdle, those are generally considered flat bones. So a lot of those flat bones, they're going to be more spongy bone, and that's where that red marrow is going to be produced throughout our lives. Clavicle and scapulae, those are flat bones. If we, when we're on campus in a couple of weeks, I'll be going through, so we'll be doing nervous system dissection, some brain and eyeball, but we'll do that toward the end. That only takes about maybe half hour, 45 minutes total to do those 2 dissections. So the first part of class, when we meet back up, we'll talk a little bit about the skeleton and the vertebra, and the muscular system as well. So anyway, and you'll see some of the muscles and bones that I'm talking. Irregular, so those are flat bones. And then we have oddballs, those are called irregular bones. Generally, they look more kind of like puzzle pieces. They don't really fit the short, long, or flat category. So they get kind of the other category. Those are irregular. Generally, we're thinking of all of your vertebrae. And then is a floating bone. Basically, that means that it doesn't really articulate or move along with another bone. It's usually embedded in some sort of soft tissue. Usually we call it an aponeurosis or a tendon. So the patella, or your kneecaps, those are kind of embedded in the tendon that forms from your quadricep muscles and then attaches down onto the tibia or the shin. We also have a little bone in the throat called the hyoid that could be considered a floating bone, I would say. So here again are some of the flat bones, your cranial bones, your scapulae, sternum, ribs, long bones, humerus, radius, and also your arm bones and your leg bones, as well as those are all long bones. Short bones are really just thinking about your wrists, the carpals, and the tarsals or the ankles. And we'll look at these in more detail coming up. Irregular bones, vertebrae, and pelvic bones. Again, kind of, I know I said these are flat. Anyway, I guess they consider them irregular in here. That's just nice. I kind of figured that that it would, but because the clavicle and scapula are flat bones, this is basically your lower body pectoral girdle, your lower body clavicle, and these are kind of like the clavicles here, and this is a lot like your scapula. So that's why they had them classified as the same type of bone. They're both pretty flat. But over time, I think they figured that these look a little more irregular, and they are pretty thick. The pelvic girdle is pretty thick. Anyway, your patella, those are your floating bones or sesamoids. So bone marrow, I mentioned a little bit ago, again, red blood cells are produced in red marrow. Now, when we're children, all of our skeleton is producing red marrow. Once we complete the process of growing in height or in length, we see the red marrow converts to yellow in the arms and legs. But in the rest of the body, that axial skeleton primarily, and then a little bit with the scapulae and the pelvic girdle or the hip bones, we continually have red blood cell production. Why is that? Well, red blood cells lifespan is only 120 days. So when a red blood cell is born in the bone marrow, it only lives for 4 months, 120 days. And one like just the tip of your pinky probably has like 20 million red blood cells. So you've got trillions and trillions and quadrillions probably of red blood cells in your body. So in every 120 days, anyway, you have a constant production of red blood cells, hopefully. And why do we need red blood cells? They're oxygen carriers. So red blood cells distribute oxygen throughout your body for all of your cells, primarily going back to our cell talk. Remember the mitochondria? And again, this is a little bit of physiology, but you might as well hear it now too. Remember those little beans, the little mitochondria, those are the powerhouses of the cell, and they are the oxygen utilizers. So when you're bringing in oxygen, red blood cells are picking up that oxygen in your lungs, and they're delivering the oxygen to the cells of your body. Specifically, they're delivering the oxygen to the mitochondria of the cells of your body. And then the mitochondria are going to use that oxygen, and they're going to generate pyruvate, and ultimately you're going to get some energy, some ATP out of the deal. You're going to get a lot of ATP just from a little bit of oxygen. Now, so anyway, that's why you need red blood cells. It's also why you need to breathe, bringing in oxygen and right. Deep breaths, diaphragmatic breathing is extremely important to cycle oxygen in and carbon dioxide out. We know that cancerous tissues generally cancerous cells become cancerous tissues, which become cancerous organs, but the cancerous cells, basically they go rogue or they mutate, usually due to chronically acidic conditions, usually involving excessive carbon dioxide buildup. Carbonic anhydrase isn't functioning the way it should, so you get carbonic acid. So it creates kind of an acidic environment, and that can trigger hypermitotic cells. We also see that we're starting to link excess consumption of sugars to certainly obesity, type 2 diabetes, but also to certain types of cancers, because the body is, instead of using oxygen as one of the mitochondria, using oxygen as their primary source for getting the optimum amount of ATP, we're using fermentation of sugar in the cytoplasm or the cytosol of a cell to go through what's called glycolysis, and you only get, a couple of ATP out of that. And so that is very problematic. So so a sedentary lifestyle and a lot of sugar consumption can lead to some serious problems long term with the body. And the system, we know this, and so that keeps people coming in. We're very busy dealing with all of the homeostatic imbalances that come or are the result of poor lifestyle, and that includes, again, sedentary lifestyle, consumption, lack of awareness regarding consumption, dehydration, and generally just malnutrition. So malnutrition, lack of sleep, and lack of movement, that's a recipe for disaster. And that's why most folks are chronically ill or even acutely ill, and why they're in the clinic, even right down to your aches and pains and your fibromyalgias and your just arthritic aspects. And so anyway, yeah, it's a lot of what we get into with in advanced A&P is that kind of stuff. So anyway, but you should know that at least a little bit now. Plenty of job security for us in the medical establishment, though, I'll tell you that much, because from what I can tell, especially these last few years with whatever was going on with our immune systems and whatever was in the air and in whatever else, there's a constant influx of homeostatic imbalances, constant influx of triggers that get the sympathetic nervous system out of whack, the stress system. So yeah, keeps us busy though. So that's a good thing. Keeps us out of trouble, I guess. When we look at a long bone, there are a couple of aspects I need you to see. The outer covering of a bone is called periosteum. So we don't have periosteum on this bone. We stripped it off. So what we're left with is the most superficial aspect called compact bone. So you can see the compact bone is very dense. What we call the shaft or the diaphysis of the bone is going to be primarily compact. But we also see at the ends of the epiphyses more of that compact bone. And then at the ends of the bone and partially lining the medullary cavity, but definitely the bulk of the ends or epiphyses of your bones, we're going to find spongy bone. This is where a lot of your red blood cell production is taking place, that spongy bone. And then we have the cavity of the marrow. They call it a marrow cavity or medullary cavity. And again, within that long bone is going to be bone marrow. And as I said before, in adults, bone marrow is yellow in our long bones. So your long bones marrow is yellow when you're an adult. Can it convert back to red? Yep. Oftentimes we'll see cancer patients that are undergoing chemo. They're under a lot of duress and stress. They have oxygen problems, red blood cell issues. So the yellow marrow will start to convert back to being red, so they can attempt to create more red blood cells. Chemotherapy destroys a lot of things. As much as it does to the cancers, it also destroys a lot of healthy tissue. So let's look at some bony landmarks. We've got the ends of your bones are called epiphyses. One is an epiphysis. We see that prefix epi, which means upon. So we have our terms proximal. Remember, proximal means closer to closer to something. For bones, it's what's closer to the shoulder. Closest to the shoulder, if it's an arm bone, is most proximal. Closest to the hips is going to be most proximal for the legs or the lower appendage. So distal means closest to the fingertips or the toes. So when we look at the femur, and this could be the humerus, this could be any of our arm bones or leg bones, but we see the end that's closest to the shoulders or the hips is called proximal epiphysis. The other end of the bone, furthest from the hip or the shoulder, is called the distal epiphysis. And then the shaft of the bone we call the diaphysis. The Greek goddess diaphysis or diaphysis, but just sounds like it would be, right? Zeus and Diaphyses fighting against bone marrow cancer. So anyway, so we've got yellow bone marrow in that medullary cavity. So we could probably conclude this is a fully grown adult. Couple other items of note that we have here, this epiphyseal growth plate. So when you guys look at what's called osteogenesis or bone growth, what we're going to see in these long bones are growth centers. And these growth centers over time, they start to ossify or harden. And what we're left with is some. There's that word periosteum. Again, that's the covering of the bone. So from superficial to deep, you'd have periosteums, most superficial, then compact bone, then spongy bone, and then you'd have the medullary cavity, and then the bone marrow. All right, a little bit of compact bone histology. Remember, histology is the study of tissue. So we'll specifically look at bone tissue. We have what's called it looks like kind of like tree rings, right? So we look and we see a bunch of little kind of tree rings here. And one word we see is osteon. Then we see osteo all over the place. You see that osteocyte, osteoclast, osteoblast. Osteo everywhere, osteon. Okay. There we go. I've got different.
We're gonna have to.
Oh, so Victoria. There we go. I have to adjust a few things on my end for visuals purposes. A couple of things that I would say are important to know. So an osteon is going to be kind of the total bone grouping. So a general bone cell is called an osteocyte. You see the word cyte and osteo. So a bone cell, osteocyte. When we put a bunch of osteocytes together and we have different canals, we have central canals, we have what's called an osteon. So a grouping of osteocytes or a bundle of bone cells is called an osteon. So that term you might recognize or see at some point. More likely you'd see the word osteocyte. Now, so 3 terms before we did osteon, that's the whole group, okay? And then there are 3 major cells of an osteon. The mature cell is called osteocyte, okay? Which makes sense because you have cell and bone. So know that and you would just by the word. Osteo means bone, cyte means cell. So if you ever see the word osteocyte, it means bone cell, okay? Now we have 2 specific types of bone cells beyond just the mature osteocyte. We have an immature baby bone cell that builds bone. There's a lot of B's. I emphasize the B because we have this word blast. Osteoblast. Blasts are baby bone cells that are solely responsible for building bone. So osteoblasts build bone. So remember at the beginning, I talked about stress on a bone can lead to more bone being produced and bone spurs. So osteoblast activity can outpace any other activity that's going to give you bone spurs or excess bone growth. So on a HESI exam, you might see asking you to differentiate between an osteoblast and an osteoclast and an osteocyte. You might just know a blast builds the bone, and they're younger, immature. A clast chisels bone. Okay, so blast build it, clasts chisel building. By the way, in cell talk, when you hear the word blast, it means we're building something. And oftentimes that building involves some explosive kind of activity. So anyway, blast. Osteoblast is building bone, laying bone out. Then the clasts, they're a little more mature. They're kind of the parent. They come in and clean up the mess. So the clast has to come in and chisel away some of that excess bone that the blasts are maybe laying out. In fact, the clasts really are the buffer. They kind of buff the bone and smooth it out a little bit. So blast and clast activity have to be evened up in order to have the optimum bone structure. If I have too much clast activity, not enough blast activity, I'll wear bone away, right? So excess chiselers will create bone density depletion. Okay, too much blast is going to give you excess bone. So we have to have homeostatic balance between blast and clast activity. If one is out of whack, the other one's not doing enough. And that can lead to either excess bone, which is a blast gone crazy, or not enough bone, which is clasts gone crazy. They're depleting bone density. Okay, does that make sense? Blasts and clasts, and they're constantly working together as we put stress on bone. What puts stress on bone? Well, repetitive use of muscle, isometric, where you're sitting all the time and you're not really moving, but you're pushing against something. That's isometrics. High heels or any type of excess heel on a shoe can lead to heel spurs, because the tendon, the Achilles that comes down to your heel, it starts to, it stresses out the calcaneus or the heel. So blasts respond to stress, building bone. And if there's excess stress, you have excess blasts. Clasts can't keep pace with the blasts, and so you end up with bone spurs. So those are the big dogs, blasts and clasts. Then when they're fully mature, they become an osteocyte.
Thank you. I read ahead and I found this section to be a little confusing, to say the least.
Oh, this is physiology. So it's how does it work? So, but it's also a little bit of microstructure. So the osteon is the umbrella term for the bone cells all coming together. And then, by the way, too, notice, guys, blue and red, and you'll notice blue and red throughout the semester when we're looking at visible body. Blue implies more or less that we're dealing with a vein. Again, more or less. We have one exception of blue and vein, and we'll talk about that down the road. But for now, blue means vein, and it also means low oxygen blood. Red means artery and oxygen. So if you see red, that means and by the way, red blood cells carry oxygen. So anyway, the red is always going to the cells. So when we see the red, this is arterial blood that's been pumped from the heart and is being delivered into the bone. Because one thing that these blasts and clasts need to function is oxygen. They need to produce, they're not producing, they need to generate ATP. They need to have an energy source on the cellular level to perform their actions. So all of these red tubes are bringing oxygenated blood, which is oxygen and sodium and phosphorus and potassium and chloride ions. All of that is coming to the bone via these red vessels. Okay. Now, bone is very vascularized because of all the red blood cell production, for one thing. So we need to get red blood cells out of there. So that's going to be what the blue. The blues are transporting blood back to the body and to the heart. So those red blood cells that are getting produced are going to be dumped into this venous return. Okay. Again, that may be a little bit of cart before the horse, but you need to know it anyway. Also, trabeculae are plates. So this osteoclast blast activity, a lot of that's going on in the spongy bone. The trabecula or trabeculae are plates. They're like bony kind of plates. That's what makes the spongy bone spongy. Okay. So in the compact bone is where we're going to find the osteons and the osteocytes really exclusively. And within that is where we're going to see mainly the delivery of oxygen and other nutrients. And this is providing the bone with strength. Whereas the spongy bone, trabecula, that's providing a lot of the red blood cell production. It's near the marrow. This is where that's what's mainly going on there. Regardless, notice there's a lot of blood supply. That's the big thing with bone, tons of blood supply. We have what's called the central canals in each of these osteons as well. A lacuna is basically it's like a bony cavern for the osteons to rest. So the osteons kind of are in a bony little cocoon. That's called so that's how I remember lacuna is kind of like a cocoon. Cocuna is how I remember that. So a lacuna is basically like a little divot or a cocoon inside of the compact bone where the osteocytes live. Canaliculi means little canal. So notice you have all these little canals, and again, that's going to be for communication. That's going to be for transport of nutrients, removal potentially of nutrients. Bone is primarily calcium. Okay, so this is physiology real quick. Bone is mainly calcium, and muscles primarily need calcium to function. So when my heart contracts, when my bicep contracts, that requires calcium. So the skeletal system contains a ton of calcium. So if my heart needs calcium, I can leach it right out of my bones. So that's what a lot of these little canaliculi are for, is for transporting. So bone will get the message. What's this yellow thing, by the way? Blue is venous blood, low oxygen. Red is arterial, usually in oxygenated blood. Yellow is fat. Typically, when we see yellow in a tube, it's going to be indicative of a nerve. So when the brain gets a signal from the heart says, I need more calcium, but maybe I'm asleep, so I'm not eating calcium. So I'm asleep, but the brain gets a message from the heart muscle says, I'm kind of struggling on calcium, I need some more. So the heart sends that to the brain says, okay, I'll take care of that, sends a signal to some of your bone and says, hey, we need some calcium. And so the message gets sent. And so we might get some osteoclast activity. So the osteoclasts kind of break up bone and provide calcium to the bloodstream. So then the heart gets blood through this venous return. Heart gets blood sent, or gets calcium then sent to the cells of the heart. So then my point is, we almost never have a shortage of calcium. And that's good, because if the heart runs out of calcium, it won't beat. That rarely happens. That's not happening generally, because we have bone, and bone is full of calcium. And so anyway, calcium homeostasis is a big deal. And that's maintaining bone calcium levels based on consumption, but also getting the right amounts of vitamin D and getting the right amounts of ultraviolet exposure. So UV exposure, vitamin D, and calcium consumption all have to be in balance in order for us to use calcium for muscle, but also to store calcium in our bones. So then when we need it in between meals, we have calcium constantly available to supply the heart specifically, but also any of your muscles that help us talk, move, do anything we need to do. Okay, so anyway, a lot of blood supply, a lot going on there. Central canal. We'll just keep going. This is in your assignment, right? Something kind of similar or akin to this. So you can click on any of these items. Again, like I say, there we go. Things get slow. Osteons, there we go. Blood vessels in the central canal. Okay. This talks a little bit about that osteoblast and osteoclast. Again, if we're low on calcium, clasts can break up some of the bone matrix and get the calcium removed. Blast, build bone. Synthesize in chemistry talk means to build something or make something. Decompose, decomposition is the opposite of synthesizing. Osteocytes, again, they're the mature bones that provide us with the structure. Okay, bone growth and formation. That just gives us a video. You guys are you can watch that on your own, but the long and short of this is, no pun intended, when we're in the womb during embryonic development, our skeleton is cartilage. As we progress to being a fetus in the womb by about week 8 or 10, we start to become fetus, and bone cartilage becomes a little more bony. And by the time we're at 40 weeks and we're ready to leave the womb, although some are never ready, right? But anyway, once we're ready to leave the womb, it's usually because the skeleton is pretty bony at that point. We're starting to, it's easier for mom to deliver a big bundle of soft cartilaginous than a big bag of bones. So it's a good thing that the fetal skeleton remains pretty soft and cartilaginous. But so anyway, cartilage shows up as blue, meaning it's avascular. You'll see different, you'll see the bony growth at the shaft of the bone. And then it basically, bone grows toward the two epiphyses. So you have growth going up and growth going down. And then you'll have these ends of the bone. See, this is hyaline cartilage, which is blue, so there's not as blood supply yet. But you can see there's a little bit of there'll be a little bit of a bony ossification center starting to form as the baby gets a little bit, or the fetus develops. And so you're going to have growth in the shaft primarily, and then the second, as it lengthens, they eventually kind of come together there. Okay, let's look at long bones of the limbs. Hold on. Oh, some more growth plate histology. You don't need to. This is beyond our scope, I would say. Just know the word ossification or osteogenesis, but usually they use the word ossification. That means bone is forming. Okay, the formation of bone. Again, this is more physiology, so we're just gonna stay in our lane. And more cartilage histology. We looked a little bit of this last time, but we can see that hyaline cartilage with that nice, pretty kind of milk glass appearance. Fractures. This is pathology. I won't spend a heck of a lot of time on here, but you might see a question at some point. I don't think on the HESI, but I think the NCLEX might have a few questions on fractures. Because again, your nurses, not all nurses are going to be working in orthopedics. So, but you may be working in general practice and often, or emergency medicine. And either way, you know, musculoskeletal stuff is very common. So anyway, a closed fracture, a simple fracture, that's the easiest one for us to work with. Closed meaning it didn't break through the skin, and simple means it's a nice clean break across. An open fracture means it broke through the skin, and compound means that we have a separation going on there. Green stick, man, that's usually from some sort of blunt trauma, but we'll get usually some sort of hairline issue going along with that green stick. So you'll have almost like a split right down into the bone there. Very painful. Comminuted is this is a shatter job. This usually involves plates and screws and a whole lot of problems. Youch. And then impacted, that's usually again from a fall where you might get the bone breaks and then it actually just kind of like partially goes up into another part of it. So you got bone, but the complete bone, then it fractures and it kind of shoves up in. Again, usually requires screws and plates and pins. Ooh, so anyway, take care of your bones. Bone repair. Nice little video on that. More calcium homeostasis. Again, you can watch that. if you'd like, or read through that. Again, this is physiology. We cover this next semester. About week 1 or 2, I think we get into this pretty early. Week 2, I believe. So anyway, thyroid and parathyroids help with calcium homeostasis. And that's going to be in the throat area. Okay, there's the thyroid. So we're going to have, again, I mentioned that the brain is constantly being given signals from the body that tell the brain what its needs are. And calcium in the blood is one of those big dogs, along with glucose. So calcium homeostasis and glucose homeostasis are a big deal. But again, that's physiology. I don't want to get cart before the horse. Osteoporosis. So condition of porous bone. So we have healthy bone and then porotic bone. All right, let's talk about a few bones. I'm gonna do my best. Laryngeal, yeah, I feel like I've got some laryngeal issues. So skull, we have the laryngeal skeleton that has to do with your voice box, your vocal cords, and then the vertebral column and the thoracic cage. So let's look at some of these skull bones. We have cranial bones and facial bones. So we're going to focus on cranial bones first. There they are. Then we'll talk about a few facial bones. All right, first bone up, the base of the skull, we have the occipital bone. Now there's a couple of bony landmarks. By the way, a bony landmark is generally, again, a muscle or ligament attachment site, or it's a hole, or it forms a joint. So a hole in a bone is for blood. We saw it back on the microstructures for the for our osteon and our bone, but we saw the red and the blue and the yellow going through the holes in the bone. So holes in bone imply that we're going to probably have blood or nerve going through. So we see a giant hole at the base of the skull. This is called the foramen magnum, the big hole. The occipital bone also articulates with the top or superior most vertebra of the neck. So there's the occipital bone. Parietal are on top. So you have one occipital, two parietals. They form the crown of the head. Temporals form your temples. You can see the connection between occipital, parietal, and now temporal, all kind of blending right in there with one another. The temporal is a dynamic bone. It has a couple of features. One is your ear hole, called the auditory meatus, or basically ear canal. And then you have, it's actually called the external auditory meatus, but, or the EAM. Anyway, meatus is how you spell meatus. But that's a meatus is basically a short canal. And then you also have a process. Here's a process. Here's another process. And here's yet another one. A process is just what it sounds like. It's something that protrudes. Process. Are you afraid of the process? I probably am a little bit. But anyway, so this is a process. This is called the mastoid process. That's that big bump right behind your ear. Mastoid process. Some of you maybe heard of mastoiditis. This area can get infected. It's very porous bone in there. And if you can get an ear infection, that can sometimes lead to problems with the mastoid. This is called the styloid process. It's kind of a pointy, there it is, kind of a pointy little jobber. But yeah, you don't want to palpate that. That's between the edge of your jaw and the muscle and your mastoid. So that's deep. You see your ear hole? It's deep to your ear hole. It's very spiky. Styloid means needle-like, like a record player has a needle. The needle's called a stylus. This is a styloid process. All right, this is called the zygomatic process of the temporal bone. So anyway, and then the ear hole again, frontal, keep removing, frontal bone. Frontal bone is your forehead. Frontal bone has a couple sinuses or caves in there. Oops, I forgot sphenoid. Sphenoid makes a little appearance kind of between the temporal and the frontal. You can see it's kind of squished in right there. That's the sphenoid. There are sinuses in there as well. Those form kind of the back of your, that's kind of a butterfly shaped bone. It also forms kind of the posterior aspect of your eyeballs, or your eye sockets, not your eyeballs, but your eye socket, your orbital, we call it. So one of the main bones of the orbital. Then the ethmoid bone is kind of like the roof of the nasal cavity there. Also forms that septum. Okay, so then they give us some bony landmarks. Again, foramen magnum is probably the major bony landmark. You're going to want to remember with that. Now, if you were going to go into orthopedics or physical therapy, maybe surge tech, but definitely orthopedic or physical, anything with athletic training, physical therapy, chiropractic, rehabilitation therapies, any of that is going to involve needing to have a knowledge of these bony landmarks. But as a GP or cardiac or mommy baby nurse, you know, any other type of nurse other than orthopedic, you're probably just going to have to know the basic names of the bones, not much bony landmarks. Sella turcica, that's part of the sphenoid bone. That's this little divot. That's where the pituitary gland sits. And again, the ethmoid, this is the roof of your nasal cavity, as well as forming part of the septum. But this is where you see little tiny holes. Whoa. You see little holes right in here. That's the critiform plate. This is where your optic, or not your optic, your olfactory, your sniffer nerve bulbs rest right in here. So when you breathe, that's really close up. So when you breathe in through the nasal cavity, those scent molecules travel right through those holes and attach to your olfactory bulbs, and it delivers the smell to your brain. All right, let's look at sutures. We've got 4 major sutures. The top parietal crown sutures together. Coronal brings parietals and frontal together. And then lambdoidal brings parietals and occipital together. Lambda is a Greek letter. It looks the lowercase lambda looks kind of like this. That's where they get that name. And then squamosal suture means flattened. Remember, squamous cells are flat cells. So between parietal and temporal, we have the squamosal suture. Sagittal, parietal, and parietal. Coronal divides front. Kind of like the frontal plane, right? The coronal plane, coronal suture. Fontanelles, those are the soft spot of a baby. You can see soft spots or fontanelle. You don't need to know the specific names, just equate. So if you ever see this word, fontanelle, know that that's the soft spot of the baby's skull. That's the clinical term, fontanelle. All right, facial bones. We've got the jawbone called the mandible. Then we have the upper jaw called the maxilla. And then we have your cheekbones called the zygomatic. Okay, so zygomatic's your cheek. It connects with the temporal bone there. This forms what they call the zygomatic arch. Zygomatic arch. So temporal bone meets the zygomatic bone, and they form the zygomatic arch. This is called the temporal process of the zygomatic. This is called the zygomatic process of the temporal. Just as a side note. Okay, so that forms the lateral aspect of your orbit. I think 7 bones form that eye socket. Saw sphenoid earlier. Of course, frontal forms the roof. Maxilla, you have 2 of those, 1 on each side. Now, if these don't fuse, notice they fuse together in the womb and at birth, right? If this doesn't fuse, if there's a separation here, that's called a cleft palate. So here's the palate right here, hard palate. Okay, so if this doesn't fuse properly, that leaves a space there. That's called a cleft palate. Okay, so anyway, maxilla, there are sinuses in the maxilla. Then mandible is your jawbone. Forms a joint right here. We have the mandible forming a joint with the temporal bone. See that right there? So when you open your mouth, this is the joint, temporal bone, mandible bone, joint. So they call this the TMJ, temporomandibular joint. Okay? TMJ. A lot of and notice right by the ear hole. A lot of people have a clicking jaw. They grind their teeth. They might have some sharp stabbing pains up in their jaw area. It pops, it clicks, it cracks. They might have hearing issues. They might have sinus problems even related to that. Chronic headaches. So the muscle that closes the jaw actually attaches right along up here and passes through this zygomatic arch. So that temporal muscle is what closes your jaw. And so if you have a lot of tension in your temporalis muscle, then you'll clench your teeth, and that can lead to tension on this joint. TMJ disorder, they call it. Keep moving. Oh, oops. We got a couple other bones of note here. Palatine bones, we kind of talked about. This hard palate is part of the maxilla. So again, they call it cleft palate, but really it's part of the maxilla. The actual palatine bones are a little further back toward what we call the soft palate. You know, in your back of your throat, there's that little dangly thing, the uvula. Stick your tongue way back there. You can feel like, well, if you stick your tongue in the front of your roof of your mouth, it's hard. You keep pushing your tongue back, it stays pretty hard. That's maxilla. It starts to get a little bit softer. Now you're starting to get to the soft palate, and above that's going to be the palatine bones. Lacrimal means tears. So your tear bone, tear ducts and tear bone, lacrimal. Nasal bones, where my glasses sit, nasal bones. Conchae, those are those little groove, or those little kind of ridges inside of the nasal cavity. Those are called conchae. I don't know what that noise was. It must be upstairs. And then the vomer, along with the ethmoid, here's the part of the ethmoid there, perpendicular plate of the ethmoid, forms the septum, along with the vomer. And vomer means plow. All right. You have 3 small bones. The smallest bones in the body are called ossicles. Here we go. Ossicle, you see the OSS, so it means bone. Ickle means little, so little bones. You have the hammer, the anvil, and the stirrup. They connect to the tympanum, or the eardrum. They're called malleus, incus, and stapes. That's the sciencey terms. These are the smallest bones in the body. they would fit inside of like an M&M, you know, they're that, maybe a peanut M&M. It's basically sound waves come in and they kind of vibrate your eardrum, which vibrates the hammer, vibrates the anvil, vibrates the stirrup, which then goes into this little oval window and starts to send sound waves down into what they call the cochlea. And then you see nerves coming in, and then that gets sent to the brain. These are semicircular canals of the ear. They help with equilibrium and balance. We'll talk about the ear in more detail in a couple of weeks. Foramen of the skull, those are the holes of the bones. Here's the 7 bones that form the eye orbit. Bones of the orbit. Septum, the nasal septum. So the ethmoid and the vomer, and then you have cartilage. That's this part that we can palpate. That's the cartilage. But that cartilage is connected to the ethmoid and the vomer. And then we've got the hyoid bone, kind of nestled right here. The hyoid bone is kind of hanging out underneath your mandible, covered up by a bunch of soft tissue. This is going to be the anchor for a lot of your tongue muscles, as well as your larynx and your speaking muscles. So you can see the tongue's kind of anchored to that, as well as some other ligaments anchoring the tongue. So yeah, the hyoid bone. Behind there, this is your windpipe right here, your trachea, just past the larynx. So this is your voice box here, the larynx. And this is, we call it thyroid cartilage. And this is cricoid cartilage, but yeah, this is going to help you with your vocal. Okay. Then we get down here, and we're now onto what's going to ultimately become the trachea. This is your windpipe. Then you have this little guy, the epiglottis, that's going to cover up your windpipe when you swallow food. So you have another tube, it's not on here, but behind the tongue is going to be opening into a tube called the esophagus. So every time you swallow, this little epiglottis closes off your windpipe. At the coroner's office, if the death appears to be suspicious, sometimes they'll look to see what the placement of the hyoid is. If somebody was strangled or was hanged, usually we see the hyoids completely displaced, because then it would cut off airflow to the lungs. All right, vertebral column, we're cruising along. Oops, I didn't mean to click that. All right, vertebral column, we have the primary vertebral column. These are individual vertebra. And then we have kind of the fused area. We have the sacrum. These are 3 to 5 fused vertebrae. And then we have the coccyx, which is the tailbone, which is also fused. These are 3 fused vertebrae. Spinal cord, of course, is what's running through the spinal cord, that central canal. That central canal, I don't know, it's called the vertebral foramen. But anyway, you see the spinal cord goes all the way through it, doesn't get all the way down there. It actually ends right around L1, and then you have a tail. We'll see that when we get to the nervous system. I don't know why this is. Anyway, it's nestled in. It's trying to show you how well protected the cord is. All right, a couple of items of interest, looking at a superior view of a vertebra. We have the body of the vertebra. So that's going to be the anterior portion. And then the posterior aspect, where you can palpate those little bumps, those are called spinous processes. Then again, we see the vertebral foramen is where we are going to find the spine. Until in 2 weeks, we'll look at the spinal cord. Okay. And then you have transverse processes that kind of stick out to the side. These are oftentimes where muscle attaches. You see the words mater, where's Pio? But anyway, there are the maters here. Mater means mother. These are the meninges, or the coverings of your spinal cord and brain. But anyway, that's what you can see, the spinal cord here, and then you have nerve roots coming out. Yeah, we'll look at sensory roots and motor roots. So sensory goes in, back, motor comes out the front for the response. So we'll look at that in a couple of weeks. But yeah, there you go. You can see how if a couple vertebrae are out of alignment, if the vertebrae above this one's out of alignment, it can impinge or pinch a nerve a little bit there. Spine ligaments, we're not going to worry about those. Again, a ligament connects a bone to a bone, and ligaments provide support. All right, let's look at the cervical spine. So the vertebrae are lettered, numbered, if you will, by abbreviations of what part of the vertebral column they are, and then which number we're at, going from superior to inferior. So the very first vertebra is called the atlas vertebra, and that's what's going to connect to, there we go. That's what's going to connect or articulate with, by the way, the fancy word for joint is articulation. So when I say articulate, it literally means, a bone and a bone coming together and moving. So the articulation spot of this occipital bone and the atlas bone, we call this the atlanto-occipital joint. So by the way, joints, if you haven't figured out, are generally named for the two bones involved, or the bony landmarks involved. So we've got C1 and then C2. So cervical 1, cervical 2. Cervical 1 is also known as the atlas. Cervical 2 is known as the axis. Alphabetically in the dictionary, I'm serious. So the first time I ever took A&P, I was a senior in high school. It was the fall of 1992. Holy shit, 30 years ago right now. Well, all right, happy 30th anniversary of your first A&P course, Kevin. I don't normally talk to myself in the third person like that, but it's on video now. So anyway, my point is, when I was first taught this 30 years ago, it still sticks in this brain. I remembered them because atlas comes before axis in the dictionary. So the atlas is the first one, the axis is the second one. C1, C2. All right. And then C3 through C7, those are the rest of the buggers. Okay. So you have 7 cervical vertebrae. Or vertebrae, 7 vertebrae, plural. 7 cervical vertebrae, C1 through C7. The other thing, remember too, about cervical vertebrae is that they have a second and a third hole. So they have 3 holes. So here we go. That's where the spinal cord travels through, right? And then you have these other 2 holes. These are called transverse foramen. Vertebral foramen, that's the one all of them have. That's the big hole. Pardon me, lunchtime. Breakfast wearing off, guys. All right, thoracic. So C1 through C7. We're almost there, home stretch. Thoracic, you're gonna have 12 of those, and they articulate with the ribs. Not much to say about those. Remember, they look kind of like a giraffe. Isn't that funny? It's pretty cool. It's almost just like a giraffe head. Anyway, body, spinous process, transverse processes. A facet, see the word facet over here? Facet is a little groove that's usually where either another vertebra will fit in or where the rib would fit. Let's move on to lumbar. Lumbar is your low back. You have 5 of those, so 7 neck, 12 thoracic, 5 lumbar. The old days, people used to eat breakfast at 7, lunch at noon, and dinner at 5, and they were probably in bed by 8. But anyway, breakfast at 7, lunch at noon or 12, and dinner is at 5. So 7, 12, and 5 for those, breakfast, lunch, and dinner. And here's your kind of like a moose looking face as opposed to a giraffe. So that's how you know you're dealing with a lumbar vertebra. A lot thicker body too. This central body here is bigger, wider or thicker kind of spinous process as well. Sacrum we talked about a little earlier, 3 to 5 fused. Sacrum operates with your pelvic girdle, then a coccyx, the lone tailbone. All right, so let's move on to the thoracic cage next. So the sternum is going to have 3 parts, and then the ribs, we're going to see, remember you have 12 thoracic vertebrae. You also you also have 12 ribs. 24, 12 pairs of ribs. That cough got me. Thanks for meeting in Zoom. This would really suck if we were in class. I'm hoping that next week I'm even better and then we'll be good to go. I'm pretty sure that's the way it's going to work. Ugh. God help us all. All right. 12 pairs of ribs. So technically you have 24 ribs. Got it? 24 ribs. All right, let's look at the sternum. You have 3 sections. The manubrium is the top, the body is the middle, and the xiphoid process is the little point right there. Okay. When you learn CPR, you learn to trace the ribs and then go up about a hand or so. So you want your palm area to be on the sternum, specifically the body of the sternum. The heart is right underneath this area here. We don't want to do CPR on the xiphoid process. If I started doing chest compressions here, it would puncture potentially the liver or stomach. All right, ribs, again, 12 pairs. You have what are called true ribs. Those are the first 7 pairs. 1, 2, 3, 4, 5, 6, 7. Notice they're true ribs because they truly connect to the sternum. So the sternum and the true ribs all have an intrinsic connection with one another. Ribs 7, 6, 5, 4, 3, 2, and 1. Okay, 1 through 7 are true ribs. That makes the other 8 through 12 false ribs. You can even see the 8, 9, and 10 right here kind of combine and form a chunk of cartilage that kind of blends in together with rib pair 7 here. And then we have these two, 11 and 12. Those are called floating ribs. They're also false ribs. They call them false floating ribs. That's important as well. The kidneys are protected by these floating ribs. So that's kind of nice. Boom, appendicular skeleton's done. Let's take a quick peek. We got it 7 minutes. We could do it. You've got the shoulder girdle, scapulae, and clavicles. Again, clavicles are the collarbones. Notice they meet together out here just above your humerus. They meet at what's called the AC joint. Acromion is this part of the scapula, and then C is for clavicle. Acromioclavicular joint. And then we also have a joint right here, the sternoclavicular joint. Sternum and clavicle. Those are those 2 little knobs right here. Those bumps right there, that's your sternoclavicular joint. Here's another shot of the scapula. So this is going to be a right scapula because we've got the medial border, and then we've got this shoulder socket out here, and then we have the spine, which the spine is always posterior. So I couldn't put this like this. It wouldn't on my left shoulder. This wouldn't work on my left shoulder. So this is going to be the right shoulder. So anyway, this is the spine of the scapula, spine, and then this is the acromion process. Then this is the coracoid process here. And then you have the glenoid fossa or glenoid cavity. This forms your shoulder joint. So the humerus plugs in to the glenoid fossa or the glenoid cavity. We call that the glenohumeral joint. That's your shoulder joint. So anyway, probably good to have just a basic concept of maybe these couple of landmarks, acromion and glenoid, and maybe the coracoid. And definitely know the spine of the scapula. You can palpate that. Anyway, again, if you're orthopedic. If you're not, I mean, you just need to know this is the clavicle. You know that other thing is the scapula. All right, so that's it for that. I'm not going to look at joint muscles yet. All right, so let's keep her moving. Upper appendage. First off, we're going to have the humerus. And then again, on the pinky side, we have the ulna. And then on the thumb side, we have the radius. The ulna is participating in primarily just elbow flexion and extension, whereas the radius helps us do what's called pronate and supinate. So doing this action. Okay. Supinate, pronate. So if you can hold a bowl of soup, you're in supination. If you're a professional basketball player, you could dribble the ball, so you're in pronation. Anyway, radius and ulna. Few bony landmarks of the humerus. The main one I would say is going to be the head of the humerus. That's the ball. And then you have these epicondyles. Medial epicondyles here and lateral epicondyles over here. Those relate to tennis elbow and golfer's elbow. So some of your patients may have to wear a brace or something around their forearm. Someone may come in and say, oh man, especially up where we are in Walworth County, there's a lot of golfers up there. They might, and tennis players, so they might complain of having, you know, soreness around their elbows, even if you are a GP. So you'll clinically speaking, they call that medial epicondylitis and lateral epicondylitis. So we usually treat it with, we want them to ice it. We want them to maybe wear a brace. And then for the pain, maybe, you know, again, some sort of ibuprofen or Aleve usually will help a little bit with that. But if it be, and then we also want them to work on mechanics. We don't want them to keep doing the same thing. If there's pain and swelling and an itis going on, it's usually because of body mechanic issues or repetitive use. So we need them to do something differently to ensure that they're not getting that. Anyway, ulna, that's the radius. Here's the ulna. The ulna, one of the main parts is going to be called the olecranon. Olecranon is the fancy word for elbow. So olecranon. And you do not need to know the carpal bones. You just need to know there are 8 of them. You don't need to know their names. 8 wrist bones, 8 carpal bones. There's your carpal tunnel. And then the metacarpals, those are the bones of the hand. So they're numbered. First metacarpal is the thumb, second, third, fourth, and fifth. Again, those are what form the hand. And then your digits are what we call phalanges. We're going to do this 2 minutes. This is your 2-minute countdown. Here's the pelvic girdle. You've got the ilium. That's your primary hip bone. That's the largest of the 3 that articulates with the sacrum. And then that forms the front. Let's hurry up. Ischium. That's your sit bone or your butt bone. So you can see the ilium kind of just comes down and forms your butt bone. So this is what you're sitting on, your ischium. And then we come all the way forward, and that's called the pubis bone or pubic bones. And they form a little joint called the pubic symphysis. So ilium, ischium, and pubis. Some doctors and professionals say ischium, but it's really pronounced ischium. All right, we're going to keep her moving. Oh, I did want to mention that this hip socket, or by this hole here, is called the obturator foramen. We back it up. There's the word obturator. And there's the foramen part. Foramen, remember, means a hole in a bone. And then I forgot to mention the word acetabulum. Shoot, my freaking visible body just locked up on me. Figures, yeah, it hit 140 and everything. Well, I guess, darn you, visible body. Confirm resubmission. Well, yeah, come on with it. There we go. Phew. Well, I'm not good. Oh, see, look at that. Oops, something went wrong. Oh, well, I guess we're done. So thank you. It's 11:48. That was, or 1:40. That was weird. Right at the 1:40 mark, that visible body just said, you're done. So, all right, well, that's our sign. So next week we'll meet like this again. I'll send out an announcement. We'll finish the schedule. We'll start at the pelvis again, and we just have to do the femur, tibia, fibula, ankles, and feet. We're almost done with skeletal anyway. So that seems like a good enough time to stop. And then we'll add some muscles and some of the important muscles to this. I'll bring up our sheet again and we'll go through it, our assignment 2, unit 2 assignment. Make sure that all of you are on board and that so between now next Tuesday, try to get into your assignment 2 and do some of that identification. Identify the long, short, irregular, flat bones, sesamoid bones. Do your micro anatomy of the bone. And then go and start labeling the different bones of the skull, the different bones and bony landmarks. I've got some bony landmarks of the scapula. You now know how to access those in Visible Body. You can also access them on Google. You can million ways to get to skin a cat, if you will. So and then so I'll start off next week by asking you if you have any questions about your unit 2 assignment through the skeletal system. And then again, we'll add in a little bit with the pelvis, and that was fast paced. And then we'll do the femur, tib, fib, and ankles. So other than that, then we'll jump right in. We'll look at our muscle list in unit 2 assignment, and then we'll go back into Visible Body and get going that way. All right, I'm going to stop recording.